It's a privilege to present grand rounds here. I'm increasingly impressed that science of any kind is like a river which finds its own path, and that path leads us to truth. And to all of us, this is exciting. Being interested in this quasi-illness, as you can see, has been full of controversy. And what I am going to try to do today is to tell you how this all happened, how I became interested in it, and how it does not appear so quasi to me today. The story thickened toward the end of last year when I was called by the Herpes Virus 6 Foundation Executive Secretary and asked if I would speak at an upcoming international meeting on the chronic fatigue syndrome. This was very interesting because the things that I had been saying for 15 years or more had been paid little attention to. But it turns out that an exciting study had been done at Stanford, and patients with chronic fatigue syndrome associated with herpes virus 6, 9 of 14 became remarkably better to recover after 6 months of valganciclovir, which was present orally. And in researching this, they recognized that I'd been saying something like this for a long time. As Jeff said, the chronic fatigue syndrome was defined at a meeting of academic physicians in the early 80s. Major criteria: a debilitating of fatigue in an individual who previously is perfectly well. In multiple studies of placebo-controlled, the spontaneous recovery rate is 19%. This is a progressive disease, and perhaps we can know a little more about it as we go along. The major criteria are mild fever, lymphadenopathy, cervical and axillary, diffuse muscle aches, can't exercise at all, no pathologic findings. Note, normal cardiac findings, normal standard 12-lead electrocardiogram, 4 women to 1 man, a history of people without prior disease at all. Epidemic in this country and throughout the world, not selective in terms of economic status. Among the biologic findings that have been recognized are elevated 2,5-A RNA ACE, which is just an enzyme which is active in the lymphocytes, common in viral infections, brain abnormalities originally paid attention to, present in many systemic infections, an array of immunologic activation, interferon, natural killer cells, elevated T cell activation, wildly and constantly present. These are all findings by others, not myself. An early finding from Hopkins, abnormal kill table studies. These people suddenly made upright, the blood pressure does not respond, and they're dizzy. And multiple studies showing no virologic associates, no cause, although this looked like mononucleosis from the beginning. The Sentinel case is your speaker. I had left the university, given up my tenure, and suddenly could no longer play tennis, was totally exhausted, had chest ache, was lightheaded, and I did a Holter monitor on myself, and it was wildly abnormal. Didn't have the bravery to ask any of you to see me because no one would go to a sick doctor. I flew across the lake to the Cleveland Clinic, and there it was evident that I had global left ventricular dilatation and decreased ejection fraction to the 40%. From 1988 until 1996, I did very little except change how I lived completely, and just was able to struggle through work. In 1996, I was the first patient treated as you will see as we go along. From the years, an hypothesis has grown, and hopefully this will become more apparent as we go along, that this is a persistent herpes virus infection. The herpes viruses are the most complicated of the viruses that we have. They are, there are 200 genes that make 200 gene products that are assembled in early, middle, and late sequence in a beautiful array. And the herpes viruses are several now, to 7, 8, or 9, but the three that we're particularly interested in are Epstein-Barr virus, cytomegalovirus, and herpes virus 6. And these viruses are double-stranded DNA, and we never get rid of them. When we're well, they close themselves up as episomes in an extra chromosomal site in the nucleus, and they're constantly trying to open and to begin to produce themselves. When they produce nothing, we call this the latent state, but they're constantly trying to become active again. The site of latency for EBV is the B cell. The site of latency for herpes virus 6 is the T cell. The site of latency for cytomegalovirus is the monocyte macrophage precursor. Our paradigm goes that this is a persistent effort by these herpes viruses, either as single or co-infection, to multiply. With CFS, there is cardiac involvement. There is a failure to maintain latency with an intense cellular and humoral activation. Now, many conditions can look like the chronic fatigue syndrome, and among them are adult rheumatic fever, Lyme disease, babesiosis, mycoplasma pneumoniae, and myocarditis. And many of the evidence-based placebo-controlled trials that have been done will lead to no result because the diagnosis is not carefully made. And there are patients with Lyme disease and chronic fatigue syndrome that are so confused that no study, unless it's properly set up, will lead to an answer which is meaningful. Doing work on a confusing, difficult area, particularly when one says something that doesn't make sense, that is, it does not belong to the canons of the day, and for which there is not a treatment, is always met with opposition. And these kinds of work, if they're correct, are called premature discoveries. New paradigms are met with opposition and ridicule, and sometimes lead to revolutions. These are the viruses that we're talking about, double-stranded DNA surrounded by protein capsid. Now, the working part of the virus is the tegument, where the enzymes put the virus together, make its parts together. And the outer lipid coats are picked out up firstly as the virus leaves the nucleus, and then as the virus leaves the cytoplasm as a double-stranded coat. Particularly the tegument is present, and we are speaking about failed latency, which is now called abortive infection. If this were not put together completely, pieces of the virus might be present. One might note that in complete virus multiplication, the antibody is to the outer coat, and these are the crude antigens that we measure when we ask for IgM and IgG antibody.